कितने कनेक्ट हो पार्टिसिपेंट
Dr. Nuzhat, when are we starting? Hello, Dr. Nuzhat. When are we starting?
Good afternoon, sir. Sir, we'll be starting in next 2-3 minutes. We are just waiting for MS sir to join us.
Hello, Dr. Nuzhat.
Yes, sir. Sir, we'll be starting in next. Starting in next 2 to 3 minutes. We are waiting for MS sir to join us.
Okay. Yeah.
रन कर लिया होगा। अच्छा चलो कोई बात नहीं। उन्होंने बोला आ गए। ये यहाँ से आवाज जाएगी। अभी खोला तो नहीं हुआ, ऑन तो नहीं है। अभी म्यूट करो ना थोड़ी देर। रन कर लिया होगा। अच्छा चलो कोई बात नहीं। उन्होंने बोला आ गए। ये यहाँ से आवाज जाएगी। अभी खोला तो नहीं हुआ, ऑन तो नहीं है। अभी म्यूट करो ना थोड़ी देर। रन कर लिया होगा। अच्छा चलो कोई बात नहीं। उन्होंने बोला आ गए। ये यहाँ से आवाज
or video call. I think we'll start. We have everyone with us. In the name of Almighty, the most gracious, the most merciful, read in the name of thy Lord who has created man from a clot. Read, and your Lord is the most generous, who has taught man by the pen. Indeed, knowledge is power. Knowledge brings salvation to all seen and unseen realms of the universe. And today we are here to disseminate knowledge about antimicrobials and inculcate the best practices into our healthcare system. And to start with, I would request our medical superintendent, Professor Ejaz Mustafa sir, who is also the convener of this event, to welcome this August gathering. Please, sir.
Good afternoon, everyone. On behalf of HIMSER and HSU Hospital, I welcome all the guest faculty, HIMSER faculty, and all delegates who have joined us on this virtual CME on rational use of antimicrobials. This CME is part of World Antimicrobial Awareness Week 2020 celebrations. Aim is to improve awareness regarding rational use of antimicrobials. Key objective of this CME is to encourage best antimicrobial practices among makers to avoid among healthcare professionals and policymakers to avoid further emergence and spread of drug-resistant infections. Simultaneously maintain the lifespan of currently available antimicrobial options we have. I hope the deliberations on the contentious issues regarding the rational use of antimicrobial today and provide an insight into the implementation of antibiotic stewardship program and help to devise a multifaceted strategy in the Indian setup. Thank you very much. I wish all the best for this event. Please.
Thank you, sir. I would now call upon our dynamic dean, Professor Mridu Dudeja ma'am, to deliver the keynote address. Professor Dudeja ma'am.
My dear colleagues and friends, a very good afternoon to all of you. It's my proud privilege and pleasure to be amongst you today to celebrate this World Health Antibiotic Awareness Program Week. Every year, all the international and national organizations, they gather together or to draw the attention towards the spread of this antimicrobial resistance. This has been stimulated due to high prevalence of the drug-resistant pathogens such as MRSA, VRE, ESBLs, resulting in threat to the mankind due to high infectious rate and mortality. Also, there is selection of Clostridium difficile, which results in pseudomembranous enterocolitis, which is again a life-threatening condition. Much more than this is that future also doesn't hold much hope for us due to rapidly drying pipeline for the advent of newer antimicrobials. All these factors together have created a major global threat amongst the mankind towards a risk of reverting back to pre-antibiotic era. Considering all these factors, a tripartite committee of executives of WHO decided to fix a date between 18th November to 24th of November, starting from 2020 onwards every year to be celebrated as World Antimicrobial Awareness Week. We at HIMSR and HHS Hospital are also very proud to be a part of this crusade. I'm very thankful to my dynamic team of pharmacology, microbiology, and other departments who have together decided to celebrate this event in spite of the gloom around due to COVID-19 unprecedented pandemic situation. HIMSR and HH Hospital is celebrating this week in the form of 3 days event. This is majorly to spread awareness amongst our healthcare professionals and colleagues about the judicious use of antimicrobials, making them aware of the threats due to antimicrobial resistance, and also to make them understand about the antibiotic stewardship. Along with that, for our students, an inter-college event was organized where I'm very proud to say that students from all the other colleges also participated wholeheartedly to celebrate this event in the form of e-posters and rangoli. And I congratulate the participants who have participated and the winners. Besides this, a CME has been organized with the eminent experts on this field, thereby deliberating, giving them a chance to share their expert view and deliberate on this major concern. The prime objective is here to sensitize all the healthcare professionals about this growing menace and towards the antimicrobial stewardship. With all this, I would like to convey my solidarity along with my team of HIMSR and HASCH that together we stand united to preserve antimicrobials. Thank you.
Thank you, ma'am. Thank you for that elaborate keynote address. And before we start our first session of distinguished guest lectures, I would like to thank few people who have made this 3-day event possible in this tough COVID times. And to start with, I would like to thank our founder CEO, Professor G.N. Kazi sir, for encouraging and motivating us to excel in academics and research and take our institute to greater heights. I thank our Dean, Professor Mridu Dijeja ma'am, for believing in me and supporting this extensive program at this difficult time. I thank our MS Professor Ijaz Mustafa sir for providing assistance at all levels. I also thank Colonel Dr. MS Kidwai sir for facilitating the live broadcast of this event. So we'll be broadcasting live today on the YouTube. I also thank, most importantly, my head, Professor Anura Bare, without whose support this event would not have been possible. I, in fact, started planning this program 2 years ago with Ray sir, and finally here we are executing this. I would also like to thank our IT department, especially Mr. Yusuf and Mr. Abu, for their tireless efforts for this exercise, which was spread over 3 days virtually. And finally, I would like to thank the coordination committee, Dr. Neetu, Dr. Ayan, Dr. Nishi, and Dr. Bhumika, especially for being my rock support, and the student volunteers, who are actually the driving force of this event, involving more than 13 medical colleges across the nation. I would also like to thank my seniors and my mentors who were always there to help me. And lastly, I would like to thank him, sir, for providing a rich and conducive academic environment for all its faculty. And the credit for this again goes to our proactive dean, who trusts her faculty, especially the young faculty, to explore and deliver their potentials to the full. Thank you so much, ma'am, once again. And without losing on time, we would like to start our first session of the distinguished guest lectures. And for the first lecture on rational use of antimicrobials and overview in the Indian scenario, we have Professor Parvez Kaul with us from Kashmir, my parent institute. And a few words about introducing my teacher and mentor as well, Professor Parvez Kaul, sir. He heads the Department of Pulmonary and Internal Medicine and is also the Chief of Clinical Research in University of SKIMS, Srinagar. He's also the State Task Force Chair for RNTCP and Chairman of RNTCP. His H index is 46. We have been discussing this a lot with our colleagues, an RG score of 51.65. And we'd be glad to know that he has figured out in the Stanford University's top 2% global researchers list in 2020. And we are glad to have him here. He has many awards to his credit, such as the OA Sama Oration Award, EMA Dr. K.C. Mohanty Oration Award. He also has the Pfizer Human Initiative 2004 Award, Bill and Melinda Gates Award 2016, and Distinguished Services Award for Influenza Foundation of India. He also has grants from multiple national and international agencies such as the CDC USA and the Global Influenza Initiative, the GIHSN France, and also numerous fellowships to his credit and memberships as well. And among the others, he is also the chief editor of Lung India. So we are, it's an honor to have you with us, sir. And we would like you to start with your first presentation, sir. Professor, over to Professor Parvez Kaul, sir. So are you with us?
Yeah, I'm very much with you, and thank you for that very kind and a very, very generous introduction. Can you give me the authority to share my slides?
Definitely, sir. Please go ahead.
No, because somebody else is sharing, so I can't share the screen till that time.
Yes, sir. You can share now.
Okay, I'll do that. Can you see my desktop there?
Yes, sir.
Is it okay?
Yes, sir.
So thank you for having me here for this World Antibiotic Awareness Week, and giving me a chance to speak on rational use of antibiotics. I requested you to give me an idea about the mix of the audience, and I understand there are a number of students, so it will not be a very over the board lecture. It will be a very basic lecture and overview of the rational use of antibiotics. I'd like to thank him, sir. I'd like to thank the Dean, Professor Kazi, Medical Superintendent, and especially you, Dr. Nusrat, for having me for this program. Is something that is very close to my heart. So we know, I'll start off with the Herophilus quote: medicines are nothing in themselves if not properly used, but the very hands of gods if employed with reason and prudence. If you look at the animal causes of death world over, we know that cardiovascular diseases and cancers score as the top two causes, but it is very important to note that infections contribute to a significant burden of infection-related deaths. As a result, in 2017-18, we had nearly 49 million infections and 11 million deaths. So we have the arsenal against the microbial infections is the antimicrobials, and they have gone through a passage of history. I mean, prior to the antibiotics, we had their empiric use, we had moricals, mercury, arsenic, methylene blues, then we had times of pus drainages, amputations, and mortuaries filled with patients with infections. And then came the antibiotic era when penicillin was discovered, and then as continuous stream of antimicrobials came into being, which actually enhanced our armamentarium against treating infective patients, and we had them in the fold. And there was this infamous statement by William Stott in the US Surgeon General in 1969. He infamously quoted that the war against the infectious diseases has been won. So he couldn't have been further from the reality. Because as we kept on developing the antimicrobials, the microbes kept on fighting back. They developed their armor and developed a series and a number of modifications to themselves to survive this onslaught of the antimicrobials, and they developed what we term as the antimicrobial resistance. And it was as a result of many of the modifications being an increased degree reduced in uptake, reduction in the target available for the drug, development of certain enzymes, inactivating enzymes, and extruding the antibiotic from the bacterial cell. And that led to the development of resistance. And the major mechanisms being enzymatic alterations, reduced permeability, efflux of the antibiotic from the bacterial cell, alteration of the target size, overproduction of the target. And this is operative differently in different antibiotics. And this is not only restricted to the bacterium that develops the resistance, it has a possibility of being transferred to other bacteria nearby by bacterial transformations, as you can see here, transduction by using the phages or by bacterial conjugations. Transposomes have actually now been implicated more and more in the causation of the transfer of resistance. This is a timeline of the development of antibiotics. As you can see, there has not been much developed after 2000 onwards, and the pipeline is drying up. And on the right, you can see the various timelines of the development of the antibiotic resistance. So as we have kept on developing the antibiotics, the microbes have been getting smarter and developing the mechanisms of resistance. This is from our own institute, various studies wherein we demonstrated the development of Salmonella typhi as a multi-drug resistant Salmonella typhi as a cause of infection. Then we had ciprofloxacin used in multi-drug resistant enteric fever in pregnancy, which was the first use in the world. And recently we have demonstrated the healthcare pneumonia is associated with antimicrobial resistant bugs. And then we have also reported on carbapenem resistant anti-Acinetobacter in our hospital as well. Two key factors are important in causation of antimicrobial resistance. One is the overuse, and second is the misuse of antibiotics. Antibiotics are unfortunately frequently prescribed for indications in which their use is not warranted or is incorrect or is suboptimal in its duration or dose. In addition, we also know now that antibiotics are routinely used in animal feeds. They are used to promote their growth, which are actually not known to be bacterially infected. And then most of these antibiotics are ingested by humans through consuming animal products and contributes to the development of the antibiotic resistance. And as a result of antibiotic resistance, this cycle starts. There's an increased use of antibiotics, increase in the resistant strains, ineffective empiric therapy consequently, higher rate of hospitalizations, again, increased healthcare resource use, and a limited treatment options. So this is a perpetually self-perpetuating cycle, and that leads to an increase in the resistance and a limitation of the options of treatment available with us. Irrational use of antibiotics, which is so common, is basically using a wrong antibiotic in a wrong dose by a wrong route administration for wrong interval of duration and in a wrong dosage form. And there are a number of determinants of the irrational use of antibiotics. And we have physician-related factors, which would be lack of knowledge of the physician, delayed lab results, physician fearing that there might be a clinical failure and he might use an inappropriate antibiotic. And there may be inappropriate peer norms, local medical culture. And there are many times that the physician feels that they have experience in using this, and that might not be actually backed by evidence. And patient demand of a quick fix, that is also very rampant. And then economic incentives, which have been in the eye of the storm. Pharmacist or dispenser-related determinants include economic incentives, and there have been very infamous incidents of economic incentives being provided to the dispensers or to the writers of the prescriptions for marketing purposes, and lack of regulations and enforcements, unclear role as health providers. The patient-related beliefs. Patient might believe that if I take a tablet of azithromycin, I'm going to get rid of my viral infection, and that is actually many a times a reason for the doctor to prescribe an antibiotic. Then there may be marketing pressures and lack of access to proper health care. The policy makers and regulators and pharmaceutical industry, there may be a lack of rational drug policy. Regulations might not be there, uncontrolled marketing strategies, and lack of infrastructure. These all contribute to the irrational use of antibiotics. The 4 E's are there: a lack of education, a basis on of experience, somebody bragging that I have an experience in this particular field and I use this way. That might not be backed by evidence. And so diagnostic and prescribing habits of doctors might actually contribute to irrational use of antibiotics. And expectations of the patient expects antibiotics of you, and then economics. And the consequences are you have antimicrobial resistance, you have adverse drug reactions related to these antibiotics, and then you have increased cost. If we look at what is going to happen in 2050, as you can see, that Asia and Europe are going to have a huge number of deaths attributable to antimicrobial resistant organisms. So we have to do something about it. So what is a rational antibiotic therapy? So we need to understand, is an antibiotic necessary? What is the most appropriate antibiotic for the disease or the condition that we are treating? What dose, route, what frequency, what duration are needed? And is the treatment effective? The most important thing to recognize is that we should not use antibiotics when they are not actually required. They don't work against viral infections. So we should desist from using antibiotics against viral infections like colds, sore throat, sore ears, and sinus infections. Certain general principles modulating antibiotic therapy can include host factors, and there can be an antibiotic which may be contraindicated in children, like tetracyclines. They may discolor your teeth. Quinolones in children, they might cause arthropathies. Then there may be host factors like renal and hepatic function. You would not want to use a drug which is cleared through the renal system if a patient has compromised renal function. And same is true of hepatic dysfunction as well. Beta-lactams can cause seizures in patients who have renal impairments. pregnancy, physiological state, but safety of drugs in pregnancy might actually not be documented, so you are actually not allowed to use it. And there are certain drugs that have been associated with teratogenicity, so that actually also modulates your decision to use antibiotics in this physiological condition. Then site of infection. Antibiotics need to achieve a sufficient local concentration at the infected site for effective microbial killing to occur. So abscesses might require drainage. There will be certain antibiotics that might not reach the place where the infection is, that like they might have to cross the blood-brain barrier. You might not have adequate concentrations available in the pulmonary parenchyma to have a kill of the infection. Then immune status, you may have a compromised immune function, which might actually hamper your antibiotic to work. Then presence of prosthetic material like prosthetic antibiotic, prosthetic valves, or you have prosthetic devices now in the joints, they usually do not respond to antibiotic therapy, and you generally might require surgical interventions. Then, of course, if somebody has a hypersensitivity to any of the antibiotics, then obviously you would not want to use it. Then there are certain pathogen factors, and we need to understand what is the clinical assessment that actually allows us to get an idea about the likely source of infection and the likely pathogen. And that would dictate and direct our empiric therapy. Lab investigations support a lot, and that gives us a definitive microbial diagnosis subsequently. Other considerations can be routes of administration. You might want to use parental antibiotic therapy if a patient is seriously ill, where effective drug concentrations are required to be achieved rapidly. Then there are certain drugs which might not be absorbed orally, like aminoglycosides or glycopeptides. Then oral route may be contraindicated as a result of a variety of reasons. And then we can use oral therapy and topical therapy as well. Dosage regimens are always influenced by severity of infection, age, and weight of the patient. Then standard treatment guidelines should be followed. I'm going to talk about that in a bit. And we must encourage compliance, and that would be reducing the frequency of the drug, reducing the pill burden of the patient, and that is very important. And the lengthening of the treatment, you need to understand that you need to give drugs for the shortest possible effective period of time, so as to improve the compliance and be equally effective. Then combinations can be used. You might use combinations for a better kill, but you have to be wary of the fact that you can have a high risk of toxicity, a greater chance of interactions, a high cost, and lesser compliance. You use combinations in certain situations, like you have a very severe patient with septic shock. You have a severe community-acquired pneumonia, brain abscess, intra-abdominal infections, a gram-negative sepsis. Those are the conditions where you probably would like to hit early and hard, and then de-escalate as and when your microbiological reports come in. There is a chance of a synergy between two antibiotics, and that might dictate your overkill in a patient of a severe infection, like beta-lactams and aminoglycosides, more effective than penicillin alone in endocarditis, and that is the reason that you give a combination of antibiotics for that. Like in tuberculosis, you want to avoid drug resistance, and there can be drugs that are effective in different populations of mycobacterium tuberculosis, and that's why you give a combination of drugs for treating tuberculosis. And you might want to broaden your antimicrobial activity by using an agent that actually improves the availability or that does not allow the antibiotic to be degraded quickly, like clavulanate you use, or with imipenem you can use Lestatin. The Council for Appropriate and Rational Antibiotic Therapy is the CARAT, is an independent multidisciplinary panel of healthcare professionals which has been established to advocate the appropriate and accurate use of antibiotics. And they have developed 5 criteria to assist healthcare providers in selecting the most appropriate and accurate treatment regimens. And these are evidence-based results, therapeutic benefits of the antibiotics, safety, cost effectiveness, and optimal drug dose and duration. So evidence-based, that means whenever you want to prescribe an antibiotic therapy, it should be based on clinical evidence, and the evidence should be clinical and microbiologically appropriate. We must have the highest quality of information for making decisions, and that is the highest evidence should be. And it's very nice if you have evidence from well-conducted randomized clinical trials, controlled clinical trials, rather than weak evidences from case reports and experiences or personal experiences. Then we have to have the therapeutic benefits have got to be amply clear. in order for you to write an antibiotic. And that is, you have to determine the correct diagnosis, analyze the therapeutic benefits, and the therapeutic benefit of each drug should be considered relative to the status of the patient's infection. And we must try to identify as quickly possible the causative pathogen and use surveillance data, which is national or regional, on the antibiotic resistance patterns in selecting the antibiotic. Of course, you need to look at the safety, and safety must be weighed against efficacy. And you must try to use strategies that give you maximal efficacy with minimal side effects. It may not be out of place to state that between 1975 and 2000, 48 new chemical entities were approved for use in United States. 45 of these acquired a black box warning, and 16 of them were actually withdrawn from the market. So eventually you need to understand that there's something that might not be available to you in terms of safety data prior to the development of the drug, and it might actually be your experience over time that will tell you what is the real safety in the real world scenario. And we need to use optimal drug for optimal duration. That's very important. Once you know that the etiological agent is, for example, a gram-positive or a gram-negative agent, we need to decide as to whether we want to give a narrow or a broad-spectrum antibiotic. Try to look at the resistance patterns nationally, as I said earlier, and regionally, which is more important, that you need to look at the local pathology, local ecology of the resistance patterns, and then decide about the antimicrobial choice. And we must know the individual's medical history and history of especially of a recent antibiotic exposure that increase your chances of being infected with a resistant organism. And the duration should be optimal, and optimal would mean the shortest amount of time required for clinical and microbiological efficacy. And that has an advantage of reducing your side effects and increasing the patient adherence, increasing the chance of patient compliance, reducing the promotion of resistance, and reducing obviously the cost. And the pharmacokinetic considerations have also got to factor in once we take a decision about choosing an antibiotic. We might have antibiotics that are actually efficacy is concentration dependent or time dependent, and we have eminent pharmacologists in the panel, in the audience. I wouldn't take more discuss it in greater detail. So we have to look at the Cmax. We look at the Cmax MIC ratio, that's the minimum inhibited concentrations, then the area of curve, and devise our antibiotic treatment strategies according to the pharmacodynamic kinetic considerations of the antibiotic therapy that we actually employ for treating the patient. So what can we do to promote rational use? We need to educate practitioners, and these seminars, panel discussions, updates are very important in that regard. We must look at the advertisements, and they should not block our intelligence. We must read the fine print. Like it is written, drug is 10 times more potent, and in the fine print it may cause renal damage and some. Most effective antibiotic, what is it for? I mean, for what cost, for what duration? And we must not lose sight of the fact that there are 3 C's of medical marketing. That is, convince, if you can, convince the doctor into writing it. If you cannot, confuse, and unfortunately, corrupt. We must have standard treatment guidelines available in hospitals, and these should be there to assist practitioners in making decisions about appropriate healthcare for specific clinical conditions. And they should be based on international guidelines coupled with your local ecological factors. And these guidelines and clinical pathways should be there and should be used without fail. And these guidelines should be simple, they should be credible, they should be of a same standard for all levels. Drug supply of the pharmacies should be based on your standard treatment goals, guidelines, and it should be introduced in pre-service training, like in internships and house jobs. And I'm glad that we have lots of students in the current symposium. Then these have got to be dynamic. I mean, there have got to be regular updates, because suddenly you might come up with a side effect of a particular drug, and you got to withdraw it from the formulary. And they have got to be handy in the form of pocket books, like you have formularies, a small SIMS or BNFs that we have in the West. And we must have a mechanism of a complementary surveillance for antibiotic resistance and antibiotic use. And if there is a particular antibiotic use that is associated with an antibiotic resistance to the same organism in microbiology, then we might have to rethink our strategy. And we must increase the use of diagnostic tests so that more and more antibiotic therapy is tailored to the microbiologically evidenced pathogen rather than using our empiric therapy and our experiences to treat infections, which may not be right all the time. So we need to formulate antibiotic policy, and that antibiotic policy is a corporate document that's basically designed to further the aim of the hospital to provide the high standard of patient care. And the objectives are to provide the most effective and empiric treatment for individual patients with minimal adverse effects, motivate rational use of antibiotics, and prevent resistance by use of judicious and timely use of relevant antibiotics, which is actually cost effective and rational. And the antibiotic policy should have involvement of the pharmacy department, where who create the hospital pharmacopoeia. There should be a written justification for a costlier and a broader spectrum of antibiotic. There should be introduction of a concept of stop orders. And if you're not happy that this is something that is right, we should not use it. And then there should be a constant coordination between the lab. A regular issue of resistance and susceptibility patterns and active consultations should be available from the microbiology department on a regular basis, and publication of consensual antibiotic policy for special use, like for prophylaxis or special clinical conditions, need to be available. And there has got to be a promotion of ethical relationship. That's very important, between the pharmaceutical companies, prescribers, and pharmacists. The antimicrobial management team generally that is responsible for designing and implementing the antibiotic policy comprises of an infectious disease physician, who is generally the member secretary, an infection control officer, who is generally a senior microbiologist, a clinical microbiologist, a surgeon, a clinical pharmacologist, and a clinical pharmacist. And they provide a high standard of patient care, and they should be aiming to improve the rational use of antibiotics. A pharmacovigilance of antimicrobials should be conducted, and there has to be an effective utilization of financial resources in purchase of antimicrobials, because that is dependent on the local ecology, local resistance patterns, and the local efficacy data that are available, and that eventually curbs the emergence of microbial resistance. So if we have to follow 4 R's of antibiotics in order to curb the irrational use of antibiotic therapy, that is, use the right drug, use it at the right time, use it in the right dose, and for the right duration. So concluding, ladies and gentlemen, irrational use of antibiotics is a burgeoning problem and needs address. We must follow the 4 R's of the antibiotic therapy that I said in the last slide to avoid irrational use of antibiotics. Institution of the 5 carat criteria will optimize safe and well-tolerated treatment regimens, curb an unnecessary prescribing of antibiotics, decrease treatment costs, and increase adherence. And this Dennis Mackey quote is very appropriate. The development of newer antibiotics without having the mechanism for their appropriate use is much like supplying an alcoholic patient with a finer brandy. So in this week of World Antibiotic Awareness, let's be aware of the antibiotics. Let us be aware of rational use of antibiotics so that we are able to curb the menace as much as we can. Thank you for your kind attention.
It was a treat to listen to Professor Pervez Kaul, a best clinician and researcher whom I have seen during my tenure at Sher Kashmir Institute of Medical Sciences. Thank you very much. We
Thank you.
HAC Hospital are observing antibiotic auditing, and which is being done regularly. Simultaneously, we are following national antibiotic policy, and we are using antibiotics as per that. Definitely, postgraduates, interns, our house surgeons, final year students would have been beneficial by this lecture. Thank you very much, Dr. Pervez. Thank you very much.
Thank you, Dr.
Thank you,
Ajaz.
sir.
Thank you so much.
Thank you for that detailed explanation of the topic. And now I would like to introduce our next speaker, Professor Vandana Roy. Edu, can we have ma'am on the screen? Professor Vandana Roy, ma'am, please speak. Share करना है. So next with us for our next distinguished lecture, we have Professor Vandana Roy ma'am with us. And Professor Roy is Director, Professor and Head Department of Pharmacology, Maulana Azad Medical College and Associated Hospitals, New Delhi. And she's also the Dean Faculty of Medical Sciences, University of Delhi. Professor Roy has worked with Delhi Medical Council and has been involved in ensuring doctor and patient safety. She's also in the training panel and signal review panel of Pharmacovigilance Program of India. She has been the member of Academic Council of University of Delhi, Executive Council, University of Delhi, and the National Academy of Medical Sciences. She has worked as academic committee members of Medical Council of India and also the diplomate of National Board of Examinations, University of Delhi. Professor Roy has been actively involved in implementation of Delhi government's drug policies since 1994. And she has also been deeply involved in curriculum reforms, something as academicians we all look forward to, and implementing the newer teaching methodology. And in this regard, she has initiated a cultural festival, Virasat, in Mamsi, where we have 40 artists from all across the world interact with students. And this has been taking place since 2005. She has also some awards to her credit, such as, to mention few here, is the Distinguished Teachers Award, Distinguished Service Award, Rashtriya Ekta Puraskar, Jamshed Shroff Prize for Community Service, President's Guide Certificate, and Rudra Prize for all-round best student. And once again, it's an honor to have ma'am here with us. And she would be talking on challenges of developing antimicrobial policy in the Indian setup, which is really a challenge before the pharmacologists, the microbiologists, as well as the clinicians. So over to Professor Roy. Ma'am, are you there? Professor Vandana
Can you
Roy,
hear me? Hello? I can hear you. Can you hear me?
Yes, yes, you can be heard.
Okay, thank you so much.
Yes, ma'am. Yes, ma'am. Now we can hear you.
Okay. Can you hear me now? Can you hear me now? Hello?
You are audible.
Okay, thank you so much.
Ma'am, you can share your slide.
Okay. Is it visible?
Yes, ma'am.
Okay, thank you so much. Shall I begin now?
Yes.
Okay. Good afternoon. Good afternoon, everybody. It's a real pleasure for me to be with all of you today. I only wish it could have been a face-to-face interaction rather than an online one, but we can't help it. And I would like to thank Professor Ajaz Mustafa, Medical Superintendent of HAH Centenary Hospital, and Dr. Nusrat Nabi for having given me this opportunity to come and interact with all of you. And also congratulate the organizers for having organized this CME as part of their celebrations, their three-day-long celebrations to celebrate the World Antimicrobial Awareness Week. And I'm sure all of you by now have realized the importance of this topic. WHO realizing the relevance of antimicrobial resistance and what's happening because of it has designated November 18 to 24 as World Antimicrobial Awareness Week to draw attention to the issue of antimicrobial resistance. So congratulations to Himsar for having taken this lead in celebrating the week to raise awareness about the issues relating to antimicrobial resistance. And hello. Yes?
Ma'am, please go ahead.
Okay. I have been asked to speak on challenges of developing an antimicrobial policy. The speakers before me and the sessions that you've had over the last 2 days, the first day on antibiotic stewardship, and in their inauguration, the speakers talking of the problem of AMR, Professor Parvez Kaul speaking of what needs to be done to improve antibiotic use. So we all know why there is the need of antimicrobial policy. Now, I want you to notice a point. Challenges. I have to speak on challenges of developing an antimicrobial policy and not challenges of making an antimicrobial policy. Hello? Hello? Now, a policy is a course of... Hello? Hello?
Please go ahead.
Okay, and there was a lot of disturbance. That's why I stopped.
Yes,
Now,
You're audible now.
okay. Now, policy is a course of administrative action, and policy leads to a plan, and that plan has to be implemented. Now, when you make a policy, you're actually doing the first step of what needs to be done in the plan. Making is just to bring about the existence of, but developing a policy is to expand. It's to bring about the potentialities and capabilities, etc. So making a policy is like making a draft. You want to make a city, so you get an architect, you get a city planner to draft a plan. So this is what making a policy would be. But developing that plan into the real city, you would get developers, and he would get a whole team to develop that draft plan into a full city. So that's the difference between making a policy and developing a policy. So I'm going to take you over the next 15 minutes through what has resulted in the making of the policy and how far it has developed globally, nationally, and at the state level. Now, just to reiterate, overuse, excessive use of antimicrobials has resulted in the problem of antimicrobial resistance, which is among the top 10 global public health threats we are facing right now. Currently, 700,000 people die annually because of AMR, and 10 million people will die annually within the next 35 years if AMR is not curtailed. And the maximum people affected would be in Africa and Asia. Economically, the world economy would lose more than 7% of its GDP, that is about $210 US, if the problem of AMR is not taken care of. Now, AMR or antimicrobial resistance, it's a multidimensional problem. It's not just a problem of humans, it's a problem created largely by humans, but it involves animals, it involves fisheries, it involves poultry, it involves agriculture, farm practices, it involves water, it involves the industry, the effluent industry, which is throwing away antibiotics into the sewage systems, which enter into the water bodies, which are then used for drinking and for agriculture purposes. It involves food manufacturing industry, agricultural, animals, fisheries, poultry, all lead into the food cycle. So AMR is a multi-dimensional problem involving multiple sectors. And any problem which is multi-dimensional and multi-sectoral has to be handled in a multi-dimensional and involving all the multiple sectors and stakeholders. So, deliberating upon this, not in one day, but over more than 2 decades, the World Health Organization has now evolved, realizing the multi-sectorality of the problem. They have now evolved a One Health approach. The World Health Organization, the Food and Agricultural Organization, the World Organization for Animal Health, OIE, they've all come together. And now what is being propagated is the solution to take care of AMR is by following a One Health approach. That is human health, animal health, welfare, plants and agriculture, food safety, security, and environment. So all these sectors are now working together or are supposed to work together to take care the policy plans and further develop it. So now let's see what's happened. 2001, WHO had begun the antibiotic surveillance, and the global strategy started getting formulated as the problem of AMR, awareness was increasing. 215, WHO came out with the Global Action Plan for curtailment of antimicrobial resistance. 2015, the same Global Action Plan was adopted by all the member countries of the World Health Assembly. And during that period or in that assembly meeting, it was decided that over the next 2 years, the member countries would develop their national action plans, that is NAP. So based on the Global Action Plan for curtailment of AMR, all the countries, it was suggested to them, now you go ahead and develop your national action plans, and the timeline given was about 2 years. So 2017, India developed its national action plan. We'll talk about it a little later. So just briefly, what are the strategic objectives of the Global Action Plan? Briefly, these strategic points are given in great detail in the Global Action Plan. The first is improve awareness and understanding about the problem. Second, strengthen the knowledge and evidence base through surveillance and research. Third, reduce the incidence of infection through infection prevention and control practices. Fourth, improve the use of antimicrobial medicines. So by following antimicrobial stewardship programs, and ensure sustainable investment so that newer antimicrobial agents can be discovered and developed. Now, under each strategy, there are many points given that need to be worked upon. Now, so 2015, the Global Action Plan came, and every 2 years after that, the WHO has been conducting surveys to monitor the country progress in its assembly. So I'm just going to very, very briefly show you the 2019-2020 survey results on country progress in the implementation of the Global Action Plan on AMR. And when I'll show you the slides, they are basically global maps. I want you to focus on the darker areas. So country progress. So there are about 194 countries in the assembly to whom the survey questionnaire is being sent, out of which about 140 is responding back. And what does it say in 2019-20? Number of countries which have a national action plan is Red is no action plan. Yellow is underdeveloped. Darker yellow, it's developed, the lemon yellow. And light green, it's properly developed. It's has to get operationalized. And dark green, it's in operation. So if you look at the green areas, you will notice USA, China, Arabia, Peru, around Peru, and very few Southeast Asian countries. And the lighter green, of course, Russia, Australia, Brazil, some North, South African countries, and India. So the green areas indicate the countries which have a national action plan, and these are 120 in number. Now, how many countries have a multi-sector and a One Health collaboration approach? Again, please look at the dark green areas. So again, you can see North America, Peru area, Russia, China, Australia, Saudi Arabia, Europe, some of the European countries, Norwegian countries, Sweden, Norway, Finland. So they all have a multi-sectoral approach. Now, how many are these in number? 120 countries had a national action plan, but the number of countries decreases when it comes to a multi-sector approach. It comes down to 52. Now, how many countries are raising awareness and understanding of AMR? Please again look at the green areas. They are very similar to the previous slides. Now, the number of countries now comes down to 51. So 120 have a NAP, 52 multi-sector approach, 51 raising awareness. How many countries have national monitoring systems for consumption and rational use of antimicrobials in human health? This number now comes down to 49. Again, US, few European countries, China, Russia, Australia, Saudi Arabia. A large part of South America, Africa, Southeast Asia has yet not reached this stage. Infection prevention control in human healthcare. The number comes down to, the number is maintained at 50. Similar countries, similar pattern of distribution. The focus is on North America, some amount of Europe, Russia, China, Australia, and optimizing antimicrobial use in human health. Again, similar distribution, but the number of countries decreased to 43. So we get an idea that out of 194 member states, 120 have been able to develop a national action plan to curtail antimicrobial resistance, which is 62% of the total number of countries. If you go down to the different areas, the different strategic priorities, the number decreases as you go down from multi-sectoral to optimizing antimicrobial use. These are varying between 22% to 26% of the countries that are actually being able to do this. This is actually, if you look at the position, it's actually a very positive situation. We now have 62% of the countries that have a national action plan, and many of the countries are doing one or few of the other things. So the plan is there in 62% of the countries. This distribution is showing that about more than 6.5 billion people now are being covered by some aspect of the global action plan through the national action plan. So more than 6.5 billion people, which is more than 90% of the world's population, is being covered. I won't say taken care of right now, but it's being covered by some aspect of, under the umbrella of the GAP, the Global Action Plan, through the agency of the National Action Plan. So in a short period of about 5 years, this is a considerable amount of achievement at the global level. You've got to consider the fact that the population is big, the resources that countries have are very less. So a lot of hand-holding is being done by the World Health Organization, FAO, and the World Organization for Animal Health. Now, coming to India, the National Action Plan. India adopted the National Action Plan in 2017. In April, the National Action Plan was approved by the cabinet, and it was sent to WHO by May 2017. The strategies under the India National Action Plan are similar to the Global Action Plan, except that, with minor variations, except that India in its National Action Plan has added a sixth priority of collaborations: international, national, interstate, and and to take up a leadership role in curtailment of the National Action Plan. Now let's see. So at the national level, India has a plan. Let's just very quickly have a look at what the state of the various objectives at the national level are. When you talk of awareness and knowledge, a few surveys in the public and amongst the doctors shows that these are not sample surveys. These are just random surveys whose data I'm showing you. So it's not very positive as regards awareness and knowledge. So general population, this study showed that over 70% lack knowledge, and of course using incomplete courses, using the leftover antibiotics again. The same was with the students. Over 80% doctors were following, they had knowledge, but they were following poor practices. It was worst for nurses and pharmacists. And there was a lot of reliance by the healthcare workers or the medical representatives for information about antibiotics and other drugs. Second objective of surveillance, creating evidence and knowledge through surveillance of antimicrobial resistance in the country. At the national level, a significant amount of work has been done in this. A lot of planning, regulations have come about. If you look at the human surveillance, in 2017, India enrolled into the WHO Global Antimicrobial Resistance Surveillance System, GLASS. The ICMR, or the Indian Council of Medical Research, has initiated the Antimicrobial Resistance Surveillance Network, in which 20 centers have been identified under a national coordinator for collecting data on antimicrobial resistance and patterns. And all this data is being put together to help formulation and progress of the policy. In animals, there was no surveillance system, but with the help of Food and Agricultural Organization, establishment of the Indian Network for Fisheries and Animal Antimicrobial Resistance has been set up. As regards food, surveillance of antimicrobials in food, Food Safety and Standards Authority has released antibiotic residue limits for meat products, poultry, and milk, which is very, very heartening. As regards environment, the environment and the climatic, the environment, forest, and the climatic ministry has come out with draft standards for antibiotic residues of 121 antibiotics, and as pharmaceutical industry influence. And this has to yet be, it's in circulation right now. These draft standards have just come about in 2020. But so it's very heartening that regulations, a system of surveillance and regulations of what should be the levels of antimicrobials in food products, in the fluids, at least they have evolved. Level strategy 3, infection prevention and control. National IPC program or operational plan is available, and all the hospitals, health facilities wanting to get accredited with NABH have to have this program, and they have to be following it, both public and the private hospitals. There is a water, sanitation, and hygiene, WASH, environment health standards, they're there. But the problem is with implementation, but the standards have been developed. We only have to get them into a operational, into an implemental mode. The fourth objective, rational use. Now, Dr. Call in this previous talk spoke about having national treatment, about having treatment guidelines for antimicrobial use. So we have them. The National Center for Disease Control, NCDC, in 2016 came out with the treatment guidelines for antimicrobial use for infectious diseases, and ICMR, Indian Council of Medical Research, followed with similar guidelines in 2017. Antimicrobial Steward Program guidelines have been brought out by ICMR, and very important, the Drugs and Cosmetic Act was modified, and there is a separate H1 schedule for antibiotics, wherein they can only be given by a pharmacist on production. The patient has to produce a written prescription by a doctor, and antibiotics under the H1 schedule, the pharmacist has to keep a copy of the prescription. He's got to keep a record of the antibiotics he's sold under the H1 schedule. The government also banned the use of colistin in livestock, one of the last resort antibiotics we have for very serious gram-negative infections in humans. So these are very, very positive. All of these are very positive aspects. Fifth and sixth strategy to promote investment for R&D into antimicrobials and collaboration. Now we know India has great potential, a very vibrant pharmaceutical industry. So novel innovations, focus on probiotics, vaccines, they have to do, and they would be doing. And of course, collaboration both these areas are areas which are not the focus of which are really not the focus right now, because we have more the government at the central, at the national and the state level has many more things to cover up. Now, so following the National Action Plan, the states, the next thing that had to follow was the states making their individual state action plans. So between 2017 and 2020, 3 states have evolved, have developed their, have made, I won't say developed, their state action plans. Kerala in 2018, Madhya Pradesh 2019, and Delhi in January 2020. But these plans, the strategic objectives have been defined, and the process of developing them is on. So they have been made, they have to be developed. So when we talk of issues in implementing antimicrobial policy, I would like to focus on on India and our National Action Plan. So you'll realize what the problems are. The state action plan is there in 3 states, that is 8.3% of the state and the union territories. There are 28 states and 8 union territories. So 36 mini countries, actually, each state is like a mini country that have to be covered. We've covered 3, we have 36 more to cover for formulation, for making a state action plan. Developing, like I said, would follow. Awareness, monitoring and surveillance. So we have a surveillance system set up at the central level, but this has to permeate into the states. It has to permeate till the last healthcare facility. Infection prevention and control, very operational guidelines are there, but again, implementation is the issue. And rational use in humans, animals, poultry, fisheries, agricultural, you all know the situation. We have a lot of ground has to be covered in these areas. India is a big country, and a vast country with 138 crore people, 45 lakh healthcare providers, 3,000 pharmaceutical companies, of which with 10,500 manufacturing units. And of course, like I said, 28 states and 8 union territories. So when we talk of a national action plan, making is easy, but developing it means taking it to the last person, the last healthcare provider, the last manufacturing unit, the last state and union territory. It is a very, very tall order. So, so far, India has been very, very active in making its national action plan. collaborating with all the international organizations, WHO, FAO. Uh, the state action plans have started developing, but we need to, we need to escalate and we need to hasten, we need to fast forward a little bit what we are doing. So maybe we need to go into a mission mode. We need dedicated and focused manpower. Whatever manpower is being used is being shared. Uh, Microbiologists who are doing other activities, administrators who are doing other activities, at the ministry level, the administration, the bureaucrats, the doctors, microbiologists, everybody is, this is something in addition to their other work. Uh, Teams have been formed, but these teams need to widen, they need to become bigger, because like I said, India is a very, very big country. We need to change from a microbiological to a social perspective. So far, the focus in all the deliberations, whichever I've been a part of, whatever you read, has been on the microbiology component. Microbiology has a big role to play in that. They will tell us the extent and the prevalence of the resistance and to which antibiotics. But beyond that, AMR is not just a microbiological problem. It's actually a health problem. It's a social problem. It's an economic problem. So we need to go beyond looking at it from a microbiological point to a social health perspective. And we need to involve social scientists because a lot of behavioral change is needed. An ecosystem needs to be created. It has to be with the government of India. Health, environment, sanitation, water, food, agriculture, animal, fisheries, poultry, and of course, food, and the public. So an ecosystem involving all these, like a One Health approach, yes, it's there in the policy. Yes, it's there on paper, and we are trying. But like I said, we need to fast forward or amplify our efforts in whatever we are doing. So what is needed? We began with the global action plan, and then we went down to the national action plan, state action plan. This needs to evolve into the district action plan, into the city action plan, town action plan, village action plan, healthcare action plan, healthcare facility action plan, till it reaches the 138 crore individuals in the country. So, so if, for AMR curtailment in the true sense, we need to reach to the last, the last mile has to be reached. The last person in the last mile has to be reached. And we need to think about it in those ways. Only then we will achieve what we are trying to do. So this is a quote I've just picked up, and I'm sure all of you are familiar with it. If we are not careful, we will soon be in a post-antibiotic era. And for some patients and for some microbes, we are already there. Alexander Fleming said, "The unprepared mind cannot see the outstretched hand of opportunity." He meant this for something else. He's talking about his discovery of penicillin and him getting the Nobel Prize. But if you look at, this can also be taken, if you look, and in the 1940s, Alexander Fleming had already talked of resistance coming because of misuse of antibiotics, and resistance to penicillin had actually come within 4 years of its discovery. But in the 1940s to the 1980s, we were not worried because as resistance was developing, newer antimicrobial agents were evolving. But that is not the situation now. Resistance is there, and we can't see any new antimicrobial agents in the pipeline. So what I would just like to end by saying that the outstretched hand of opportunity right now is the hand given to us to do whatever we can to curtail the problem of antimicrobial resistance. And if we don't do this, we are going to be in big trouble. So let us avail of the opportunity given to us by providence, created by man, to do whatever we can for AMR, antimicrobial resistance, lest not our future generations lament if only our forefathers had done what they should have. Thank you.
Thank you, ma'am. Thank you for explaining
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
behind the policy making. And definitely, yes, we need to amplify our efforts, ma'am.
Thank you, ma'am.
And I would like to share here with all of you. Yesterday, we had the e-poster session in the Art Integrated program. And one of the posters which bagged the third prize, it had the caption was the end game, the superhero's end game. And the villain was the penicillin. And the superhero was the superbug. And perhaps we are in the end game, and we have these superbugs becoming the superheroes unless we become the real heroes, the mankind. So once again, thank you so much, ma'am, for explaining this policy making in detail. And we would now move on towards our second session, the panel discussion. And I hope we have all the panelists and our dynamic moderator with us. So we have the second panel discussion on implementation of antimicrobial stewardship. So, you know, we are all knowledgeable enough, but we are poor on our attitude and practices. And that is why we have to deliberate upon this very important issue, that is implementation of antimicrobial stewardship in the Indian scenario, Indian perspective. So we have our moderator, Professor Sangeeta Sharma with us. We're glad to have her. Can we have the slide, please? Yes, so the moderator for our panel discussion is Professor Sangeeta Sharma, ma'am. And she is the professor and head, Department of Neuropsychopharmacology in the Institute of Human Behavior and Allied Sciences, New Delhi. She is also the president of Delhi Society for Promotion of Rational Use of Drugs. And it's an NGO which is at the forefront of promoting rational use of medicines since 1996. Professor Sharma has also done her QMA, HO, and MBA in Healthcare Administration. And she has served as the Secretary Medical Council of India and as a technical coordinator of India WHO Essential Drugs Program. She is a certified healthcare quality leadership in patient safety program from the Harvard Medical School. And she is also, one of her pioneering work is the book Standard Treatment Guidelines, a manual for medical therapeutics, and which is in its 6th edition. Yes, it must be a great read. I would definitely like to have it. And yes, now we hand over the panel discussion to Professor Sangeeta Sharma. Ma'am, are you there with us? Good afternoon, ma'am.
Good afternoon.
Over to you.
Yeah. Can you tell all the participants to mute their this thing? Good afternoon, everyone. I think the panel discussion and the topic for the conference was very much apt. I thank Dr. Nusrat Nabi and the Dean and Shoma Mukherjee for, inviting me for this workshop panel discussion. We know the importance of the AMR. Dr. Vandana Roy was talking about it. The AMR pandemic. We are, in a stage where this another impending pandemic we will have to face in future. That is AMR pandemic, and some people call it a slow tsunami. which we are not appreciating today, but it has come. We can't shut our eyes from this any longer. And if we don't take any action today, there will be no cure tomorrow. We have seen the golden era of antibiotics. We know the miracle by the of the antibiotics, but we can also, this COVID pandemic has shown us how AMR, if we develop this AMR, how helpless we will be when even simple illnesses will not be cured. So implementation of all these principles of AMSP has gained even more important in the context of COVID-19. Anyway, this, I take this as a silver lining of the black clouds. COVID has resulted in so many deaths, but this is an opportunity. If others can wake up and we start implementing AMSP principles in our day-to-day prescribing. Today on our panel we had 6 people from different specialities, and but somehow Professor Musharraf Hussain cannot join us because he's running high-grade fever. He's not well. So we'll have 5 panelists with us. Dr. S. Mukherjee, Sudipta Mukherjee, he's a consultant critical care, Tata Medical Center, Kolkata. He's also a NABH assessor at pre-entry level. Young talent, he was awarded by Young Talent 2019 by Indian Society for Critical Care Medicine. Is Dr. Sudipta Mukherjee online? Yes, he's there.
Good afternoon, ma'am. Good afternoon, everybody.
Afternoon. Welcome to the panel discussion. Can we just start? My question, if you can begin with, what are the major easily implementable antimicrobial stewardship interventions in your practice, and what has been your experience about utilization of national or the state or the hospital level treatment guidelines in promoting antimicrobial stewardship?
Thank you, ma'am, and thank you, everybody. Good afternoon. Thank you for inviting me into this with these esteemed panelists for this very opt topic in the present era, that is the antimicrobial stewardship. And myself working in the ICU of a tertiary care cancer hospital, we deal with lot of multi-drug resistant bugs, and progressively the usage of all these broad spectrum antibiotics are increasing in our regular practice because of increasing infections. A lot of patients are very sick, so eventually this usage of these broad spectrum antibiotics in our practice is very much required. Now, as ma'am has already mentioned, we have also discussed that there is not much new antibiotics are coming or present in the panel. So what we have to do, we have to use whatever we have, whatever the antibiotics we have judiciously. We have to preserve them as much as we can and try to use them in appropriate scenario, and most importantly, try to de-escalate them when the patient is doing fine or when the patient does not require an antibiotic. Now, we in Tata Medical Center has an antimicrobial stewardship team, which is led by our microbiology consultant, Dr. Sanjay Bhattacharya. I'm also a active member of their group, and we're also working with ICMR. So whatever the national level policies are presently developing, we are actively involving in that. So first important aspect of implementation of an MSP project is to have a team which understand the importance of antibiotic stewardship. They understand the usage or appropriate usage of drugs, so that they can train, they can utilize, they can develop a policy and share that with other clinicians, so that we can have a better antibiotic usage and better outcome. So as I already mentioned, along with our clinicians, we have clinicians from other different disciplines, because medical oncology, hematology, post-surgical patients are also requiring broad spectrum antibiotics. Along with that, we have infection control nurse, who usually help us regarding the collection of data and showing or developing our infection of our antibiotic consumption rate, DDT and DOT, along with the drug resistance. Next important thing is to train our physicians, train our colleagues regarding the 4 Ds of antibiotics, that is the right drug, right dose, right route, and the right duration or de-escalation. Among these 4 Ds, the first three is uh, easy to implement. It is easy to teach. The difficult part is the duration of antibiotics or the de-escalation. It sometimes becomes very difficult to convince a clinician that this antibiotic is not required in your patient, or already we have given this antibiotic for enough duration. Again, in this aspect, the most important part is training and being actively involved with the patient. So suppose I see a patient and advise that please stop this antibiotic. Obviously, the primary clinician who is giving this antibiotic for next 5 7 days are not comfortable. So what we do, we ensure them will follow up that patient. Now, once your MSP team or when a clinician from your MSP team ensure that we'll follow up this patient in the next few days, and we'll see and review our advice that whether need for a escalation of antibiotic or de-escalation of antibiotic, and whatever is needed to discuss with the primary team and convince them regarding the further management. It is much easy to implement our policy or implement our decision making. Third is regarding usage of empirical antibiotics and targeted antibiotics. Now, for empirical antibiotics, we need a hospital antibiogram, but that is basically which decide your empirical antibiotic in a hospital. As Madam was and previous speaker is also discussing regarding the national and international policies. Now, may not be, it may be a guide or it may be a starting point, but eventually you have to develop your own antibiotic policy for your hospital, because the antibiogram of each and every hospital usually varies from areas to area and also from a tertiary care to a secondary hospital. Suppose in my hospital, a lot of patients are immunocompromised. They come and go, they receive chemotherapy, they require frequent admission for different type of therapy. As a result, most of them get colonized with MDRO. They are immunocompromised, being a post-cancer follow-up patients. As a result, these patients are require much broad spectrum antibiotics like colistin, fosfomycin, TG-cycline very frequently. This may not be the scenario in case in a tertiary care hospital when they are mostly dealing with a community-acquired infection. So eventually, in my hospital, even the community-acquired infections are MDR because these patients are coming and going to the hospital. So whatever the international or national policies we have, those may guide us. They may act as an initial point to start our work, but eventually we have to develop our own policy or own antibiogram. And in this regard, ICMR is working very intensely. They are promoting all the hospitals to develop their own antibiogram, doing the test, looking at the sensitive sending culture of cultures, whether whenever we are starting antibiotic or escalating antibiotic, whether we are sending cultures, appropriate cultures to the lab, and whether we are following out with that. But second is the targeted antibiotics, because that's why we can de-escalate your antibiotics and save those broad spectrum antibiotics. In this regard, one is a standard conventional culture. Along with that, there are multiple PCR techniques are available. If we can follow up them and implement in our hospital, that would be great. We are following some of the PCR techniques by which can look at the resistant pattern, like whether the drug is carbapenem resistant, whether it is colistin resistant or not. And what we do is with this, we usually give a prospective feedback. We follow up all those patients, we look at the antibiotics they are getting, and then we discuss with the primary consultants that your patient is getting A, B, and C. In my opinion, depending on his clinical scenario, probably he is not requiring so much antibiotics. We can maybe cut down on C. Another option is restricted formulary, which is little difficult in Indian scenario when a lot of patients are admitted under different consultants, but it can be implemented for some of the antibiotics, specifically the broad spectrum antibiotics like fosfomycin or colistin, and specifically from the new generation antibiotics, which are mostly targeted antibiotics, something like ceftazidime avibactam or meropenem verbactam or those type of scenario. Because this type of antibiotics can be applied only when you have a specific carbapenem resistance. So you need to know that gene and you need an input from your microbiology team. So in this scenario, you can use a restricted formulary or pre-authorization when the clinician need a confirmation from your microbiology team or infection control team before prescribing this type of medications. And one of the most underestimated things we all know, that is the hand hygiene or the standard precautions. This should always be the cornerstone of any form of infection control prevention. And we need to, as an MSP committee, we need to implement it, we need to promote it. We need to do a regular audit that we are doing and share that audit data with our clinicians, with our nursing staff, and we need to work much harder to improve this. And at the end of this, we need administrative support, we need an authority so that we can decide antibiotic policy, and if required, you can step in and can change your management for our patients. So these are the basic things presently we are doing and try to implement or improve on these regards. Thank you.
Thank you, Dr. Mukherjee. You have beautifully summarized. I think the implementation part is the most difficult one, but you have summarized in very easy steps, and let me share with you, behavioral modification is the most difficult task. Most difficult task.
Very agree, ma'am. Very difficult.
It is very, very difficult. It is easy to say that you de-escalate and do this or stop at the earliest, but it is very difficult for the to convince the clinician. He says it is my patient, I need to safeguard his health. So what will, if and I think you have rightly said, if the team, if you have a passionate team, dedicated team, and who can instill the confidence in the clinician, that they are there to take care of the patient and nothing. And if you go back to them with the data of the patients who got better applying these AMSV principles, perhaps it would be easier to convince them.
Exactly. And we also convince them that we will follow up your patient. Suppose I am working ICU. Whenever the patient is going out of ICU with the broad spectrum antibiotics, we ensure them we will follow up and we'll try to de-escalate within 40 to 72 hours of a significant clinical improvement. And now they have a confidence that yes, infection control team will follow up my patients and they will try to do whatever they can for the best interest of our patients. So that confidence we are trying to generate, and to some extent we are successful.
That's great. I think you'll be able to continue this good work. And I think another way of behavior modification could be if you go back to them with the data, with the antibiotic use data, and then what change interventions were done and what is the outcome. I can briefly share my experience in my own hospital here. We have a neurology ICU, a lot of meningitis patients come, and I did this DDD methodology to measure the antibiotic consumption, and I found otherwise it was okay. All antibiotics were near the recommended DDD, but I found piperacillin was used as an empirical antibiotic, and but when the patient was shifted to ward, the piperacillin was continued, so they never de-escalated that. It could have been de-escalated. The immediate reply I got, why this was there, so they said no, patient was stable on piperacillin, I didn't want to touch this patient. So maybe can you elaborate on this?
Yes, ma'am. This problem we also face, that whenever patient is getting a broad spectrum antibiotics and patient come out of a very critical scenario, maybe out of ventilator. Now on day 7 or day 5 of antibiotics, we are shifting the patient out of ICU and plan that probably will continue antibiotic for another 48 hours and then probably will stop. But if sometime we get a referral after 5 or 7 days when the patient is already getting 2 weeks, or in sometime more than 2 weeks of antibiotics, and they are asking us that we are planning to discharge this patient, can you do you like to change this IV antibiotic to something oral? And they are very reluctant to stop antibiotics because the patient has improved from a critical condition. Now that, as I mentioned, as a behavior, we once we share data, we try to arrange small CMEs within the hospital in different occasion on the bend of a standard antibiotic infection control meeting, or sometime as an academic program. We share our understanding regarding management of infection, sharing our understanding that most of the time in infection, the antibiotic duration 7 to 10 days is more than enough. In very rare situation, we need to go beyond 10 days. Sometimes we need to continue because our patients are immunocompromised, but otherwise 7 to 10 days of duration of antibiotic is enough. So what we presently practice, so suppose I'm shifting a patient out of ICU, we usually document on the medicine chart what should be the anticipated duration of antibiotic and when they need to discuss that with us. So we put a ask on the medicine chart, maybe after another 2 days, and after that they usually give us a call that you put an ask on the medicine chart. Do you like to continue? What do you think? Should we stop it? So we review the patient and probably we take a decision accordingly. And most of the times, as they are doing fine, we probably able to stop antibiotics. But only thing is, once the clinicians are convinced that we are not just shifting them out, we are giving some advice without follow up. They are circumspect. Once they are convinced that this team or these doctors will follow up on my patient, and then they are more comfortable and they are okay with our decision.
Thank you, Dr. Mukherjee. I think very useful tips were provided. Some of these messages, our participants would like to take back home and to start practicing in their clinical practice when they go back. Now, may I have Professor Syed Juar Rahman? He's a old colleague, pharmacologist from JNMC. He's a National Secretary, Society of Pharmacovigilance, India. He's been trustee and treasurer of IBN Sinha Academy of Medicine and Sciences, Medieval Medicine and Sciences, International Association of Medical Colleges. Dr. Rahman, are you there? Good afternoon. Seeing you after a long time. Can you unmute yourself? Please unmute. Unmute yourself. Unmute. Yours is muted. Yeah. Hello? We can't hear you. Your voice is not audible. We can't hear you. Nusrat, can you hear him? I can't hear him.
Ma'am, we can also not hear him. We are trying to unmute him from our end. We'll see.
Okay. Okay.
We are trying.
Can you speak something, Dr. Rahman? Can you speak something? We are not able to hear you.
Ma'am, sir is unmuted.
Unmuted, but can't hear him. Maybe he has some problem. Maybe you can ask him to log out and log in again.
Yes, ma'am. Yeah, I'll have a word with sir, and meanwhile we can continue discussion with other panelists.
Yeah, we can continue with the other. Dr. Smita Sharma, are you there? Dr. Smita?
Yes, ma'am. Yes, ma'am. I'm there.
Good afternoon. Very good afternoon. Welcome to this panel discussion. Thank you for agreeing to be the part of this important panel discussion. I think this subject is also very close to your heart. Let me introduce. She is an associate director and head clinical microbiology and infection prevention and control at Medanta Hospital, the Medicity Gurgaon, and she has represented India as the SHEA International Ambassador in 2018. She has been very closely involved with our work also, DSP RUD programs, and when we do training programs for doctors and the nurses, she's also a very passionate worker on these aspects. Maybe can we start the panel discussion for you with what is the role of diagnostics in AMSP program, and how do you come across any barriers, and what possible solutions you found out to overcome these barriers while implementing the antibiotic stewardship program in your hospital or in your experience at other institutes as well?
First of all, good afternoon, ma'am, and good afternoon to all the other panelists. And thank you so much for giving me this opportunity to participate in this discussion. Now, coming to your question, diagnostic stewardship is all about doing the right test at the right time and on the right patient. Now, diagnostic stewardship, antimicrobial stewardship, and infection prevention and control are the three pillars for the theranostic approach in controlling emergence of and spread of drug-resistant organisms. Timely and accurate microbiological results will help the clinician in selecting the most appropriate antibiotics for the patients, as well as to implement the necessary precautions to reduce the risk of transmission of infections in the hospital. Now, diagnostic stewards embraces all these stages of the diagnostic processes. It starts from appropriate history taking, clinical examination, and deciding on the appropriate tests for that particular patient, and also proper collection of the sample, which is very important. We need to stress on the fact that whenever we are sending sample for culture, cultures like blood cultures, like CFF samples, we need to maintain proper aseptic conditions. Otherwise, there will be contamination of the sample. Then it also depends on how we process the sample. And finally, how you interpret the test. Interpretation is very important. We have to differentiate between colonization and contamination, because finally, at the end of it, it is the disease that we are targeting to treat and not the pathogen. Now, basically, by diagnostic stewardship, what we are targeting two things. First, in helping the clinician for choosing the appropriate antibiotics, and secondly, to help in formulating an antibiogram. If we have the data on antibiotic drug resistance and we are able to maintain that data, so we can help in formulating the antimicrobial policy for the particular hospital. Now, coming across barriers in implementation of diagnostic stewardship, if you talk about our hospital, the two most important requirements for diagnostic stewardship are, first, in my opinion, would be resources in terms of manpower and the equipment. And the second would be the availability of a protocol or the process for implementation of the protocols. Now, coming to the first requirement, if we talk about Medanta, our lab has almost all the necessary automated equipments which are needed for rapid diagnostic of the infectious parameters. We have the MultiTop, we have the BioFire, Gene Expert with us, etc. So we are very lucky that our management is very supportive in terms of helping us to get all the recent or new equipment that comes in the picture. Moreover, there is an interfacing of our laboratory instruments with the laboratory information system. So this helps in releasing the reports as soon as they are ready, and this can be accessed by the clinicians as well. We have an electronic medical record system. It's an app. So through these apps, reports can be accessed from remote sites as well. And our antimicrobial stewardship program is also through this EMR app only. And we must thank our IT team for this. Now, coming to processes, so our lab is enable accredited. Therefore, the quality protocols are strictly maintained for all the tests. The lab runs 24 into 7, so there is no delay in processing of the sample, and we cater to almost all the necessary tests which would help in differentiate between bacterial viral infections and all the between infectious and non-infectious parameters. Collection of samples, contamination of samples, so these are collated and are there's a feedback is given to the stakeholders on a regular interval so that they can improve the processes over a period of time. And we have a critical alert mechanism also, which I feel is very important, because many tests like a positive blood culture signal or a growth in a CSF or a significant microscopic finding, it needs to be communicated to the clinician so that they can relook into the antimicrobials that they have prescribed to the particular patient. So, and what we must say is that in our hospital, we have a very good one-on-one communication with the clinicians. So we go for regular rounds, and the clinician will always have a discussion with us whenever they would encounter a difficult scenario.
Thank you, Smita, for nicely summarizing the diagnostic stewardship and a lot of things which are being done at Medanta. Many of us in the government sector might think that we are not as uh, lucky or as resourceful as Medanta is, but I think that that is the future. In case we want to uh, implement these AMSP principles, we need to integrate this laboratory information system and alert system within the hospital information system, so that the communication can be done on real time basis. And I think another thing which is common, Dr. Mukherjee also mentioned, one-on-one communication is very important for the this thing. Do you think any rapid testing, diagnostic testing would be available in near future? Because I think most of the time antibiotics are misused because the clinician is not very clear whether this is a bacterial infection or a viral infection. So are there any rapid diagnostic tests which are available?
The future of the antimicrobial stewardship program will depend on automation and molecular diagnosis. because very soon we will be having point of care testing. We should be having, in fact, for infectious markers. We already have point of care testing for certain markers like a procalcitonin in the high risk areas in a hospital. Like they can immediately do a procal and find out whether it could be infectious or non-infectious. Then we have the gene expert, which will help you in diagnosis of tuberculosis in a very short period of time, along with the drug resistance. Then for COVID detection also, you have this Abbott detection system, and also the gene expert, which can give you a diagnosis. So if we have a lot of these rapid tests, it will help us in diagnosis. Moreover, if we are talking about the future, it will also depend on how many multiplex molecular panels we have. Now, basically, when we talk about diagnosis, if we have a particular molecular panel including the bacterial and viral infections and also parasitic infections, so we can easily rule out bacterial from viral infection and can target our therapy accordingly. So availability of other rapid tests like lateral flow assay, or it could be different card tests, which they can also help us in rapid diagnosis. For example, in case of malaria, if you want to have a rapid diagnosis, if these are available at point of care, probably the diagnosis could be rapid, but that there could be issues with logistics, in the sense like how do we report such tests if the test is available at a clinical area. So how do we put, so these things that we need to sort out. And the most important thing is about rapid diagnosis is the availability of a critical alert mechanism, which we already have in place. So since our systems are interfaced with the LIS and HIS, so critical alerts are automatically generated. So this kind of technology would, help a lot in deciding on whether we need to change any antibiotics. For example, we have this blood culture automated system. Whenever there is a positive signal, so we do a gram staining, and then we raise a critical alert to the clinician, and it's also visible in the HIS. So this will help them in de-escalating from a broad empirical therapy to a directed therapy specific for gram positive, gram negative, or fungal infection. So these would help. That is what I believe.
Smita, can you just explain a little more about the adequate sampling? Most of the time, the culture is not positive, or it comes no growth. Most of the time we feel that perhaps the right sample was not drawn, or right technique was not used, or the right timing of the sample was not there. And that is why many times you get a contaminated sample, and then we go on treating this contamination rather than the infection. Can you briefly touch upon this?
Yes, the first thing whenever an infectious etiology is suspected in a particular patient, the first thing is to send the sample even before starting the antibiotics. That is the basic requirement in an antimicrobial stewardship program, which I believe. Because if the patient, if an antibiotic is started, it is very unlikely. If it's a broad spectrum antibiotics, we may not grow the pathogen at all. So that is the first criteria that we need to take care of before starting antimicrobial. The second is adequate or appropriate collection of sample. So if you're sending a blood culture, it also depends upon the volume of blood in the blood culture. If the volume is less, so obviously our chances of isolating the organism would be less. So out here at Medanta, we have this protocol of sending the blood cultures in two sets. Each set has an aerobic and an anaerobic culture. So for a particular patient, so you have samples from two different sites, and each sample from each site will be processed both for aerobic and anaerobic culture. Now, if you're growing a coagulous negative staphylococcus in one out of the four samples, so you know that it's a contaminant. Now, if you're going that coagulous negative staphylococcus in all the four samples, then probably you can rethink. It could be a cause of the bloodstream infection. And moreover, since ours is an automated system, we also look into the time to positivity. So if a central line sample, the time to positivity is 2 hours earlier than the peripheral line, so you can think about it being a catheter associated bloodstream infection, and plan how to manage that kind of a patient. So this is about blood culture. Even if when you are asking a patient to collect his own sample, like a urine sample, proper instructions should be given on how to collect. And the clinician should also know like what samples to send. Like if a patient is catheterized, there's no point sending a urine sample because the catheter gets colonized within 72 hours of insertion. So whatever you might be growing, it may be just a colonizer, and we don't need to treat it. So there is a very thin line between deciding whether you want to treat it or not treat it, because you have to have a clarity on whether you want to, regard that particular isolate as a contamination or as a true pathogen. Therefore, we always encourage the clinicians to send us detailed clinical history along with the sample that they are sending, so that we can give them appropriate report. So probably, and also like targeting, like if you are suspecting a bloodstream infection, so the samples that you need to send would be a blood culture, or it could be a urine sample if you're thinking about urosepsis, or if it is a remote site from which you think the infection has spread to the bloodstream, so those samples should be sent. So because if you keep on sending, there is a habit, I mean not a habit, so it is a practice with most clinicians that they ask the nurses or the junior consultant to send all the samples, like send all cultures. But then if you're growing one isolate from each of the culture, you do not know how to prioritize. So we have to have proper clinical history and then decide on what samples that we want to send for a particular diagnosis.
Thank you, Dr. Smita. Uh, can we now move on to the next speaker, panelist, Dr. Rahman? Are you there?
Yes, ma'am. Can you hear me now?
Yes, yes, we can hear
Okay,
you.
thank you so much, Dr. Sangeeta Sharma. It's really nice to see you again here. And
Yes.
before we go for my part, I would like to thank Nusrat Nabi for giving me this chance to interact with you all in this panel discussion, and Dr. Ejaz Mustafa Saab. Thank you so much. So it will be my pleasure to interact with you all here.
Dr. Rahman, could you elaborate on, what are the important principles related to antibiotic therapy, and how our traditional, teaching is different from what is required in the clinics? We do talk about general principles in pharmacology, but students, when they go to the clinical practice, they find it very difficult to apply these principles over there. Can you elaborate on these, how to do this, and how this gap can be built up?
Okay, so being a pharmacologist, what I feel that we usually in the in teaching, every method is has advantage and disadvantage. If we, as you said, what are the drawbacks or the disadvantages in the traditional teaching? So most of the time the traditional teaching is based on the didactic lecture. We all know that we used to hear lectures, and it's usually done in a large group teaching. And most of the teachers, they focus only on the mechanism of action based classification and the classification of pathogens and microbes. So what we found that most of the lectures, they are not clinically oriented or not problem based teaching. And usually teachers usually don't teach about the risk of the over prescribing. And what I can say is most of the time applied part is missing in the traditional teaching. And if we come to the recent curriculum part, then which is the curriculum-based medical education. So here, the good thing is we most of the time focus on the integrated teaching, where we can interact with the in the horizontal integrated teaching. We can collaborate with the microbiology department and can teach all our students, which could be clinically oriented or problem based. So likewise, with this teaching, we can improve ourselves, or this is the way with which we can see that Dr. Samita, what she was telling is all about. So that could also be taught in or to all the undergraduate students also. Not only the didactic or the one-way lectures, but also the practical part. So not only in the theory classes, we can also cover all these things, which is needed to make the program successful. The antimicrobial stewardship. So practical part is also very important.
Thank you, Dr. Rahman, for highlighting the requirements. I think we need to, restructure our teaching, because patients do not present as they, that I am infected with so and so bacteria, whereas we teach, antibiotics, that they are effective on this bacteria. Patients come with the syndromes or the disease.
Hmm.
So, there is a challenge to identify the disease correctly.
So
Then
what
only.
Yes, so what we can do is we can also teach the most important principles related to the antimicrobial therapy. Like, for example, as you because you are a person of rational use of drug, and Delhi Society for Promotion of Rational Use of Drug also promote how to use the drug rationally. So we can also teach our students in the same pattern. Like, for example, we can ask students that before prescribing any antibiotics, we should have accurate infectious disease diagnosis. And this accurate infectious disease diagnosis could be based on the clinical orientation, like, for example, site of infection, for example, with the host characteristics, based on his age, immunocompromised condition or comorbidities, and most accurate diagnosis could obviously could be made by the microbiological diagnosis. So foremost thing is accurate infectious disease diagnosis, and then we can teach students when to initiate the antimicrobial therapy. Like, for example, in the critically ill patients, we can ask that antibiotics should be started immediately. For example, in septic shock, for example, febrile neutropenia, or, for example, the meningitis. So we can also teach students, like, before we start these in these conditions immediately the antibiotic, but at the same time we can also teach students, like, they need to have concurrent collection of the samples as well as all at the same time. Similarly, for the stable clinical circumstances, we can delay the antibiotic therapy, because we need to have the confirmed diagnosis, and we can wait till the microbiological diagnosis, for example, in subacute bacterial endocarditis, where we need to have multiple set of blood culture. And because for the presentation in these diseases, there is time. And similarly, in the vertebral osteomyelitis and gastritis, so there is no need to start a drug immediately, and it's very important to have the correct diagnosis. After the diagnosis, then we can, as we have already discussed about the empirical and definitive treatment. So we need to tell our students, especially undergraduate students, the basic principles, like when we can start the empirical treatment, or what is the difference of empirical and definitive treatment. For example, empirical treatment can be started in the very ill patients, or and in the conditions like endocarditis, septic arthritis, disk space infection, or meningitis. Similarly, definitive treatment can only be in the confirmed diagnosis, or where the diagnosis is confirmed. For example, cellulitis, where we all know that it could be because of Staph aureus. So we can have direct antibiotic therapy for conditions like cellulitis. So this is and for usually we also need to teach students, like, in definitive therapy we need to have narrow spectrum antibiotics, and especially, and similarly in empirical treatment we can use broad spectrum antibiotics, like beta lactam or third generation cephalosporins or quinolones. So these are the basic things which students should learn, and they can also learn either in theory classes or in practical classes. For example, how to interpret the antimicrobial susceptibility test, and what is the importance of the minimum inhibitory concentration, and then they can also may know how to classify, like, susceptible or intermediate or resistant cases. Before they go to the clinical side, they must know about the importance of MIC, or the minimum inhibitory concentration. So this is also important, and likewise, they can also learn that sometimes susceptibility test may not be feasible. For example, like if we get the sample from the CSF sample, and if we found that cefazolin is susceptible to that culture, and when we try to give this cefazolin, then this sample which is susceptible, but cefazolin it basically cannot cross the blood-brain barrier. So this is also need to tell the student that susceptibility test, although it's susceptible, but sometimes drugs are not cannot be given because they cannot cross the blood-brain barrier or some other say. And we can also teach students. There's many basic principles like bacteriostatic or bactericidal, so they should know what are the drugs which are the bactericidal, and classification like beta-lactam or daptomycin. Similarly, the bacteriostatic like sulfonamide, tetracycline. So these are basic things, and they are usually asked in the Viva OC also. So very important for undergraduate students. And similarly, they should know the importance of the antibiotic combinations. In some areas, antibiotic combinations are also needed, and they should know the synergistic effect of some antibiotic. Like we can tell them, like in endocarditis, uh, penicillin can be combined with gentamicin for the streptococcus infection, and if these drugs are combined, they are not only having synergistic effect to control the infection, but also it may reduce the duration of the treatment. For example, if this ceftriaxone or penicillin is used alone, so it needs to be given for 4 weeks, and if it is combined with gentamicin, then it may reduce the duration of treatment, like from 4 weeks to 2 weeks. So these are the things which, and similarly, we can also tell not only the synergistic effect, but also these combination may be used in microbial infection, and this combination sometimes inhibit the emergence of resistance, especially in tuberculosis or HIV/AIDS. There also combination is important. Then in the basic principle, we can also tell a student about the host factors, which is also very important, like age of a patient, like in geriatrics and pediatrics age group, you need to calculate a dose of antibiotics. Similarly, renal compromised or hepatic compromised patients, and they need to know the interaction, especially the enzyme inducers, like if ampicillin is enzyme inducer, so this may also change the response of the drug. Sometimes genetic variation is also important among the host characteristics, like we know that D6PD deficiency patients, if they are given primaquine, so they may lead to hemolysis. Likewise, we know that abacavir, which is very important in the HIV/AIDS. So patients who are having genetic variation in the HLA, human leukocyte antigen allele, then there is a chances of hypersensitivity. So these are the questions which are also not only important for YOC, but in fact needed to be taught in the classes.
Thank you.
Okay. So there are
Yeah.
many things.
Yeah,
Yes,
I think
we can teach.
the general principle can go on,
Right.
and all of these have a application in the clinical setting also.
Right.
Today time wasn't enough to discuss all of these principles. Can we move on to the next panelist, Dr. Arnab Ray? Are you there? Dr. Arunab Ray, are you there? If he is not there, can we move on to Professor Prem Kapoor?
Yes, madam. Yes.
Okay. Okay. May I introduce the panelist here with us, Professor Prem Kapoor? You may know him already, but for those who have joined from the outside, he's the head of the Department of Medicine, Hamdard Institute of Medical Sciences and Research, New Delhi. My question to you, Dr. Prem Kapoor, is, what are the clinical dilemmas you encounter in your practice? Just now Dr. Rahman told lots of principles about antibiotic therapy. What is the clinical dilemma you face when you apply these principles in clinical setting, and how, and explain a bit about the clinical syndrome approach to overcome some of these dilemmas.
Okay, thank you, Dr. Sharma. I hope most of the participants are still joined, or they have just muted and switched off their videos and gone away by now. Quite late
That's
in
the
the day.
hazard of online. You can't know, you don't know whether they are connected with you or not. But okay, we have to live with this.
Okay. I think I'll talk a little more practical, you see, because we as clinicians are the ones who are the end users of antibiotics. And this talk of AMR, it's absolutely okay, but when it comes to ground reality, the things are quite different. You see, though we talk about the 4 Rs, right dose, right drug, right duration, right frequency, this is absolutely okay, but when it comes to treating patients, it becomes a huge big dilemma as to, first of all, whether to give an antibiotic or not. You see, that's the most important. Whenever a patient comes to us, I'll give you some clinical scenarios. Like, there are situations where you are sure that the patient has a bacterial infection, and you straight away go in for using an antibiotic without doing even a culture, or at least not knowing the report of the culture. So in this scenario, like, we have patients with acute follicular tonsillitis. A child comes with high fever and he has follicular tonsils. He has enlarged lymph nodes. You straight away know that this is a streptococcal infection, and you go in for a beta-lactam antibiotic. The same holds true for, say, cases of bacillary dysentery. Loose motions with blood, tenesmus, high fever. You know that you have to give antibacterials to this or antibiotics, and then you start a quinolone to this patient. And then we have a scenario where patient comes with, say, cellulitis, as was given the example, or a UTI, where patient comes with dysuria, frequency, fever, and you have pustules in the urine, and without waiting for the culture report, most of us will start an antibiotic to this. Again, quinolones would be the first choice. But then there are situations where you are not sure whether this is a bacterial infection or a viral infection. There comes the dilemma as to whether what to do. No, there are situations like, I'll give you another example of, say, sore throat, a pharyngitis. So I don't know how many of us will wait for 5 to 7 days to see whether this is a viral infection. I am sure 90% of us also, the moment we say that there is a sore throat, little fever, body aches, and we'll start having erythromycin. You see, that is what happens on the ground. But then, is it really required? So is true for, say, diarrhea in children. Sudden onset, vomiting, loose motions, little fever. You know this is a rotavirus, but still, I get a lot of telephone calls saying, Dr. Saab, kal se loose motion ho rahe hain. And then I've started taking Norflox TZ. You see, that's invariably the answer. And then I said, why have you taken this? Because last time I had it, I took it and it disappeared. But then I asked them, are you okay? He says, I've become more uncomfortable. The loose motions are continuing. I have distaste, and now I am having nausea and vomiting also. So I tell them, Baba, this is not a bacterial infection. This is most likely a viral. Take ORS rather than take antibacterial. So these are the examples. Similarly, for fever, a short duration of fever, 2-3 days, the people go in for Vidal test, which is always prescribed by general practitioners. It invariably turns out to be positive, and they are labeled as enteric fever. Now, these are situations where you have to be prudent and decide. But we don't have patients, we don't have facilities to do cultures, and then antibiotic is started. Here, for my junior colleagues, now I'll give you some tips as to how do we differentiate that this is a viral or a bacterial infection, which is very important. Then everybody, every healthcare worker must know these principles, where to use antibiotics and where you suspect a bacterial infection. You see, viral infections are usually start with a bang. they start with high fever. Bacterial infections usually come gradually. Fever will gradually pick up from say 99 to 100 to 101, but viral fevers on day 1 you will have 101 and 102. Then there will be systemic signs of fever, like you will have body aches, you will have loose motions, you have dry cough, so you have symptoms from other systems also, rather than confining to one system which bacterial infections would cause. Then there will be more than one family members might be affected. Then it shows that this is a viral infection rather than a bacterial infection. And also in the interfebrile period, when you don't have fever, patients with bacterial infections would not be feeling normal, whereas patients with viral fever will feel so good. They will feel that they are absolutely normal and they start to move around. And then lastly, if you have some lab facility, do a CBC count, a very easy thing to do. If the counts are high, it is bacterial. If the counts are low, it is viral. So these are the few tips that you can use to decide whether this is a viral infection or a bacterial infection. And as has rightly been done, that all fevers are not caused by infections and all infections are not bacterial. So this rule has to be kept in mind while you are starting the patient on treatment, antibacterial treatment. Now you talked about this syndromic approach to illness. No, this is a concept that was developed by WHO. So a lot of resource poor countries don't have manpower to treat patients in the periphery without any expertise or without any lab infrastructure. So many times, we divide a group of symptoms and signs into syndromes. And when we treat a common etiological agents which are causing these syndromes, that's what is known as a syndromic approach to clinical conditions, where we outline the main causative agents and give the patient a combination of drugs which will cover all the possible etiological agents causing this constellation of symptoms. Like this was initially used for STDs, which is now known as STI, sexually transmitted infections, or RTIs, reproductive tract infections, which normally these days we divide them into, say, genital ulcers, urethral discharge in a male, vaginal discharge in a female, scrotal swelling, lower abdominal pain. So this is a constellation of symptoms. So giving an example, say suppose a male patient comes with a urethral discharge. So we know that this is either a gonococcal infection or a chlamydial infection. So as a syndromic approach and syndromic treatment, we give them a combination of ceftriaxone, which will take care of the gonococcus, and we give them either a macrolide, azithromycin, or doxycycline to take care of chlamydia. So this is what a syndromic approach is. This has been found to be quite cost effective. A lot of studies world over has shown that this is a cost effective means of treating patients at the periphery by primary health care workers. It has the advantage that it is a treatment given by even paramedical people or healthcare workers who can use a colored logarithm algorithms for diagnosing as well as for treatment. This can also be done at the periphery. So in the first contact, you are giving the treatment to the patient, prevents transmission of the disease. It prevents sequelae and fatalities because of the disease. And as I told you, in resource poor countries where lab facilities are not well developed, you can obviate using all the sophisticated investigations. Though they have been, initially it was used for STDs, but now we have syndromic approach for, say, diarrheas in children, for fevers in children, and for acute respiratory tract infections. So we have syndromic approach and syndromic treatment for a lot of conditions. But there have been question marks on this also. You see, some people say that this is unscientific. To some extent, this may be true also, because sometimes we are over treating the patient. Suppose somebody, as I told you the example, somebody has a chlamydia, why give him ceftriaxone? So sometimes we are over treating and sometimes we may be under treating these patients. And then this approach cannot be used for asymptomatic people where they have only very mild symptoms and only lab investigations will confirm the diagnosis. And then lastly, the most important thing to remember is that the etiologies may change. Etiologies may change from place to place and may change from time to time. So we have to be on the guard to know what are the common etiological agents for a particular syndrome. And second, the sensitivity, antibiotic sensitivity may change for these organisms from time to time, from place to place. So if we can do a good surveillance as to find out what are the etiological agents and what are the sensitivities in a particular area, if we can do that, then as the studies have proven, it is a very safe and effective and cheap way of treating a lot of diseases at the periphery by primary health care workers.
Thank you, Dr. Kapoor, for summarizing very succinctly the areas, the clinical dilemmas faced in the diagnosis and the treatment. I think clinical syndrome approach is something, which is useful for the residents and then primary care practitioners. The clinical, it at least gives you the, starting point, so that, infection doesn't spread and appropriate treatment is started. And once we have a more, clear diagnosis, the therapy can be, modified to include to address those etiological agents. But definitely this helps, in improving the antibiotic use, because one thing which is very much important is we all know when to give these antibiotics, but we should know when not to give antibiotic. That's also equally very important, because most of the inappropriate use is coming from because situations where we don't need antibiotics, but we are treating them with the antibiotics. And watchful waiting is something which we need to practice. Most of the time, upper respiratory tract, 90% we have this knowledge, but when we don't apply this into the practice, but we start giving them antibiotic, and none of the antibiotics which we have taught or learned are effective against the viruses. So but we are, so what watchful waiting is something which we need to inculcate to promote use of antibiotics in clinical practice. Thank you, Dr. Kapoor, for beautifully summarizing this very important, a controversial topic in a nice way. Do we have Dr. Ray here? Has he joined us?
Yes, yes.
We missed you. And good afternoon, Dr. Ray. You all know him very well. He's your own
Yeah,
professor here.
yeah, yes.
And formerly he was director at VP Chess in Dean. He has served in various prominent positions in VPCI, and he has been awarded several Achari Award, Uvnas Award, very prestigious award in pharmacology community, Young Asian Pharmacological Prize, B.N. Ghosh Oration Award. There are many awards. I think if I go on, we'll get late for the session. We are already
Yeah,
late.
I think you should not waste much time on these unnecessary things. Yes.
Dr. Rahman has already given us the general principles of antibiotic prescribing, and he also discussed about the factors affecting the choice of antibiotics. Quickly, can I ask you to just focus on how the therapeutic drug monitoring, PKPD principles and MIC principles can be used to improve upon the antimicrobial?
Yes, because these are most of the aspects have already been covered by the earlier speakers. So the specific question that you asked regarding the pharmacokinetic parameters. So the basic thing we need to know is that basic knowledge of pharmacokinetics is very important for anybody who is dealing with antibiotics or who is prescribing antibiotics. That is most important. And when we talk of pharmacokinetics, there are 2 or 3 things that come into the picture. One is the MIC, which is a very basic thing as far as microbes are concerned, the minimal inhibitory concentration. Other than that, there are 2 other parameters which are important, which need to be kept in mind when giving an antibiotic, is the AUC, that is area under curve, and the AUC by the MIC ratio. This is also very important. And then you have another ratio, which is the peak/MIC ratio, which also decides as to what kind of antibiotic is absolutely required in this kind of a situation. So we can do all these calculations pharmacokinetically. But like Dr. Kapoor said, that at the ground level 0, you may not have time to do all these things. So you have to make a choice on the basis of your knowledge. You have to make a choice on the basis of 2 or 3 basic things. One is related to the patients. The other is related to the drug, your knowledge about the drug. And the third thing is related to the microbe. So when you take all these 3 things in consideration and apply your basic pharmacology knowledge of pharmacokinetics, probably you will be looking at an antibiotic which should be given in this kind of a situation. So pharmacokinetic parameters
do matter, because basically antimicrobials kill in two ways. One is a concentration dependent killing. That is, the higher the concentration, greater the proportion of antimicrobial effect. And the second is a time dependent killing. So the longer the antibiotic stays in the circulation or at the site, the better chances are. So you have different antibiotics which fall in the first category, like aminoglycosides, quinolones, macrolides. They fall in the concentration dependent category. And the second category is time dependent. That is penicillins and cephalosporins classically. They have to be dosed more frequently as compared to these agents. So these are the two most important aspects that you need to keep in mind. And when you're talking of goal of therapy with reference to pharmacokinetics, you would require to maximize the concentrations. You would require to maximize the AUC versus the MIC ratio. You would like to maximize the peak versus the MIC ratio. And obviously, you would have to use higher doses. And daily dosing or less frequent dosing would do your job. But on the other hand, when you're looking at time-dependent killing, like when you use beta-lactams, that is penicillins and cephalosporins, maximum duration of exposure is very important. So more frequent dosing is required, longer infusion times are required, and you need to continuously monitor some of these antibiotics, drug levels of some of these antibiotics, which have a very narrow therapeutic index, particularly aminoglycosides and vancomycin, some of the glycopeptide antibiotics. So you need to know that since they have a very narrow therapeutic index, they can very easily go into ADRs. And one of the main objectives of doing a rational antibiotic therapy is to ensure that you don't get an ADR with an antibiotic when you're prescribing them. So pharmacokinetics, in brief, can help you in these various ways in order to guide your antibiotic therapy in a more rational manner.
Thank you, Dr. Ray, for summarizing it. The entire pharmacokinetic. It takes usually the 1 hour to explain all these things. But I think gist of it is, you need to know the concentration dependent and time that will decide the timing and dosing of antibiotic. And sometimes you have to do the therapeutic drug monitoring, because in burns patient or shock patient, the PK, PD, these things will change because of the volume.
Absolutely. Yeah.
So,
because there are certain antibiotics, where you can just measure one-time concentrations.
Yeah.
But there are certain other antibiotics like aminoglycosides where you need to measure the peak as well as the trough. So you need to have two samplings for such antibiotics. So you need to know, so these peak and trough levels will let you know that what is the exact status of the antibiotic in the circulation. So this will help you, because aminoglycosides are very frequently used in the ICU. Amikacin particularly is very frequently used in the ICU. So you need to know that when to dose and how to dose. And they being very narrow therapeutic index antibiotics, they can very easily go into toxicity levels unless you are careful with these pharmacokinetic parameters.
Sometimes in clinical practice, we very quickly arrive at a conclusion that these antibiotics are not effective or are of poor quality. But in fact, these parameters, PKPD and the peak and trough levels, which are responsible for non-response here. So it is good to.
Yes, exactly, yes.
Okay, I think we are a little late, but we started late also. There was one more panelist from surgery department was to present here, but I can, on his behalf, maybe I can say a few words on, use of antibiotics.
Sure.
This is something, surgery, antibiotic use, if you are interested in doing AMSP activities in your hospital, you have to first look at, which are the areas where most antibiotics are used. And you will find surgery is the department where, antibiotics are very frequently used. And, you may even find that post surgery period, 7 days, 10 days, 14 days, antibiotic therapies is continued. Whereas we all know that nowadays, single dose prophylactic therapy with antibiotic is advocated 60 minutes prior to surgery, especially in clean surgeries which are planned, elective. There is no need for post surgery antibiotics at all. one single dose of antibiotic is sufficient. But somehow, it is very difficult to convince the clinician. I think Dr. Mukherjee, the principles he highlighted, that you have to have a team and you need to tell them, handhold the surgeons, and get the confidence of the surgeons that a single dose will be as effective as post surgery antibiotics. Most of the time, in my experience, I have found the post surgical infections, the surgical superficial surgical site infections, are mostly because of the gaps in the infection prevention and control. They are majorly because of the poor wound dressing. Till the patient is with us, we take care of the wound also. But sometimes we discharge the patient, send them home even before the stitches are out, and then we don't know what's happening. So the wound handling is also important. We are, instead of focusing on other factors which can cause infection or which make the patient susceptible to infections, such as, diabetes control is very important. The infection prevention and control is very important. The site preparation for surgery, many a times I still find that many places they are still shaving the site of surgery. It may cause, abrasions and can lead to infection. These are the normothermia. Patient is going into hypothermia, so or hyperthermia. So these things are, which can affect the outcomes. But we are focusing, somehow we feel very much confident, I have given antibiotic, ab patient ko kuch nahi hone wala hai. But if this AMR develops, and as Dr. Kapoor was saying, patient ko ठीक होने के अलावा दूसरी और तकलीफें ऐड हो जाती हैं. So this 14 days of antibiotics will not only be a waste, but will add to AMR and unnecessary trouble to the patient. So there are, few, I think I can summarize, overall AMSP program. It is very, very important to have a team, antibiotic stewardship team in place in your hospital. Active team dedicated who is passionate about this antibiotic use should be in place. And we and it is which who should be training all the doctors from time to time, and plus on job or, bedside training should be done to when to start treatment with antibiotic. That is very important. We should know when not to prescribe antibiotic. When it comes to, prescribing which antibiotic, what, how, for how long, all these things should be adhered to. And I think very important, one of the very important strategy is that whenever you prescribe antibiotic, you also must mention the stop date. Then you can always review this stop date and extend this if required, but mentioning stop date right in the beginning will keep your mind, on track, what for the antibiotic was prescribed, for how long it would be needed. Many times I go to the wards and I find वो बोलते हैं, सिस्टर बोलती है कि एंटीबायोटिक लेना है, हाँ हाँ दे दो. वो बोलती है 14 दिन से चल रही है. अच्छा चल रही है, आई डिडंट नो, वो तो हमें पता ही नहीं था, इतने दिन से चला, अब स्टॉप कर दो, 14 दिन हो गए तो स्टॉप कर दो. दिस इज हैपनिंग बिकॉज दे डोंट स्टार्ट, तो हो जाता है पर स्टॉप नहीं होता है. So that is very important. Dr. Sudipto Mukherjee was talking about the pre-authorization or formulary restriction. See, all of you, this is very important. We can develop a list, first line drugs or aware, WHO has given this aware category, AWARE. A stands for excess. You can include certain drugs, antibiotics in this excess list so that you can make these available to all the patients who need antibiotics. Then there is a watch group of antibiotics which should be prescribed watchfully. You should watch the prescribing pattern. We should also look at the resistance pattern, because these drugs have the potential to develop resistance. So watch group, most of these third generation cephalosporins fall under this category. And reserve is something last resort antibiotics, which should be prescribed only when you don't have any other option available with you, something like cholesterol or piperacillin vaccine like things. So we can divide these antibiotics into different groups and say excess group will be available in OPD, watch group will be available in IPD, but you will be watching trend, and reserve will be only prescribed in ICU, will not be prescribed outside of the ICU. And first 48 hours empirical treatment with these drugs will be given. After 48 hours, stop orders will be there, and unless the clinician reviews and specifically makes a requisition for starting these antibiotic, then only these will. This is a very effective strategy we can implement in your hospital very easily. And of course the de-escalation part, very important part. You can, because we need to save the life of the patient, we can start with any of these antibiotics, but we need to see that we de-escalate from broad spectrum to narrow spectrum. We de-escalate from IV to oral antibiotics. That is equally important. And timing also we can review and see, how frequently do we want to give these antibiotics. And with de-escalation we can reduce the pressure on these antibiotics, and this pressure on AMR will be reduced. I think these are the and then
Sorry.
switch from IV to oral is important. Many of us think that IV medications are more powerful, oral are not. So, but many of these oral preparations are available, which are equally as effective as IV, can be used. I think with these things, I think even if this much is done, a lot of it can be achieved in the AMSP activities in the hospital. Thank you.
Yes, I think we had a extensive discussion on implementation. And thank you, ma'am. Thank you so much for moderating it so well and so passionately. Thank you so much. And I thank everyone for their time and efforts and the initiative to make this implementation on antimicrobial stewardship something that is beneficial for all practitioners. And now we have the results of our poster presentations. We had a scientific poster presentation in the morning, and we had 4 judges judging it. And we will have Professor Ray, sir, to announce the results.
Before that, Nusrat, can I thank all the panelists? I forgot to thank them all. They came up, ready with the, questions I had for them. Thank you very much, all the panelists and the people in the audience. I hope they find it useful. Please
Thank you.
Thank you, ma'am. Thank you.
Thank you so much for moderating such a nice panel discussion.
Thank you, madam. Thank you.
Yeah, thank you.
Yes, sir. Ray, sir, over to you, sir.
Yes. Yes, it is a great pleasure to announce the poster prizes. Can you hear me?
Yes.
Can you hear me?
Yes, sir.
Can you hear me?
Yes, sir. We can hear you. Yes, sir. Sir, we can.
Okay, the first prize goes to 2 people. The first prize for the posters goes to 2 people. One is Vinita from KGMC and Abhi from Himsar. So jointly, the first prize. Did you hear that?
Yes, sir.
The second prize again goes to 2 people, Soumya from KGMC and Kanta from School of Pharmaceutical Education and Research, Jamia Hamdard. So Soumya from KGMC and Kanta from School of Pharmaceutical Education and Research, Jamia Hamdard. So both of them get jointly the second prize. And the third prize goes to Shraddha and Kanta. Again, both from School of Pharmaceutical Education and Research. I believe both these Kantas are different people.
Sir, actually, sir, second prize is for Soumya and Nazia. Nazia, sir. Nazia has been missed out. I think there is a duplication in the list.
Okay.
Soumya and Nazia at 2.
So Soumya and Nazia gets the second prize. Shraddha and Kanta gets the third prize. Nazia is also from SPER, Jamia Hamdard.
Yes,
And the third prize to Shraddha and Kanta, both from SPER, Jamia Hamdard.
yes, sir.
Yes. All the best to all of them.
Thank you, sir.
Is that all?
Yes, sir. We had 27 posters, and these are our
Okay.
6 winners. We wanted to motivate all of them. And thank you so much, sir, for being with us. Thank you all
Very
the panelists
nice.
and all the. Thank you so much, sir. I think we'll end the meeting. Thank you, everyone.
Thank you, everybody. Thank you.
Thank you. Thank you. Thank you.
Thank
Thank
everyone.
you.
Thank you so much. Bye-bye.
निकले सर और जो नहीं निकले